So what I wanted to do today is share with you my research on nitric oxide and osteoporosis. So what I'm going to start with is really just sharing with you an outline, going over the pathophysiology of osteoporosis, why nitric oxide may play a role in bone turnover, some earlier work looking at the effects of isosorbide mononitrate on markers of bone turnover, and then sharing the most recent work on the effects of nitroglycerin on bone geometry and strength. So I think this is maybe in backward order. I'm just going to go to the next slide. So we know that low bone mineral density is a risk factor for osteoporotic fractures. And in fact, the relationship between hip fracture and hip bone density is about 2.6. So that for every one standard deviation decrease in bone mineral density, the relative risk of hip fracture goes up by about 2.5-fold. We also know that bone mineral density at any time is made up by the balance between bone formation and bone resorption. And we also know that there's increased bone resorption or breakdown at menopause. And that's led a lot of researchers to really focus on the role of estrogen in bone breakdown. But I think bone resorption is very complex, and there are probably a whole host of other features or factors that may play a role. And one of them, which I'd like to talk to you about today, is nitric oxide. So nitric oxide is sort of an endogenous, the ubiquitous molecule, and it has endogenous sources. Most commonly, it's made by the combination of L-arginine in the gut with oxygen. And in the presence of nitric oxide synthase, you get nitric oxide. And that's very quickly broken down into nitrate and nitrite. There are also exogenous sources of nitric oxide, and these include isosorbide mononitrate, isosorbide dinitrate, and nitroglycerin. And those are all medications that are used typically to treat chest pain due to chest pain or angina, and they actually are known to increase levels of nitric oxide and then increase nitrate and nitrite. We know also that bone cells can make nitric oxide. And there are two cell types that are involved in bone remodeling: osteoclasts, which are responsible for bone resorption, osteoblasts, which are responsible for bone formation. And osteoblasts are thought to produce enteric or E-nitric oxide synthase. And estrogen and mechanical strains produce I-nitric oxide synthase. And you'll remember that you need nitric oxide synthase to make nitric oxide. The other thing that we know is that nitric oxide can influence osteoclast activity. It seems to have a biphasic effect, so that low levels of nitric oxide enhance osteoclast activity and differentiation, so we have more bone breakdown, and high levels of nitric oxide inhibit osteoclast activity and differentiation. So theoretically, we'd have low levels of bone breakdown. One of the methods by which nitric oxide may mediate its effects are through OPG, or osteoprogenitin. And we know that high levels of nitric oxide activate OPG, and low levels of nitric oxide activate OPGL. And we also know that the balance between bone resorption and bone resorption really depends on the balance between OPGL and OPG. So clearly, if we had high levels of OPGL by this image, we would have lots of bone breakdown. And this is just an example of what nitric oxide does. So nitric oxide would act to form OPG, which would then inhibit OPGL and allow for decreased osteoclast activity. What about osteoblasts? We don't really have a lot of data on the role of nitric oxide in osteoblasts. However, we think that probably there's biphasic activity in that role as well, so that high levels of nitric oxide stimulate osteoblast activity. and low levels of nitric oxide likely inhibit osteoblast activity. So to summarize what I've told you in a very brief period of time, let me tell you that nitric oxide is thought to stimulate OPG. OPG then binds to OPGL, which prevents the binding of OPGL to rank and reduces osteoclast activity. Ultimately, this would decrease bone breakdown. The issues that come up are, is this effect that I've described with you in vitro similar with what we would see with nitric oxide donors? And does this decrease in bone resorption lead to an increase in bone mineral density? So here's a study that really looked at the effect of estrogen and transdermal nitroglycerin on bone. This was a rat study that was done now almost 15 years ago. And what you can see in the left-hand column are the type of rats. So there was a sham operated, there was a very ectomized rat, the very ectomized rats given estrogen, ectomized rats given nitroglycerin, and a very ectomized rat given estrogen and nitroglycerin. And what you can see is that the sham-operated rats had an increase in bone density of about 25% over 6 weeks. Very ectomized rats had a less of an increase in bone mineral density, and these were growing rats, so that's why everyone's bone density went up. And what I want to point out to you are really the last two columns, so the last two groups, excuse me. The very ectomized rats treated with nitroglycerin had about a 20% increase in bone mineral density. And this was similar to the rats that were treated with estrogen alone, where they had a 27% increase, and also similar to rats that were given both estrogen and nitroglycerin. So this really demonstrates, at least in animal models, that giving transdermal nitroglycerin, a nitric oxide donor, appears to improve bone mineral density. The other thing that we know is that the frequency of administration may play a role. So just to take a step back, we know that in patients who have angina, increased frequency of administration of nitrates can lead to tachyphylaxis. What this study is the frequency of administration in rats also seems to decrease effectiveness with increasing frequency. So here again, in the left-hand side are a variety of treatment groups, and on the right-hand side is the change in spine density. So you can see the sham-operated rats had a modest increase in bone density of about 6%. A very ectomized rat lost bone. If they were given estrogen, they maintained bone at about 6%. And if they were given nitroglycerin once a day, they maintained bone. However, if they were given nitroglycerin twice a day or even 3 times a day, the effect on bone mass, the protective effect, was lost. So this demonstrates that the bone seems to have a tachyphylaxis, or demonstrates a tachyphylaxis to nitric oxide, similar to the heart. Well, what about menopause? Does nitric oxide play a role in nitric oxide? Well, menopause is characterized by increased bone resorption, low circulating estrogen, low levels of nitric oxide. We also know that treatment with hormone replacement therapy, or HRT, increases nitric oxide levels and decreases bone resorption. We looked at the effects of nitric oxide and bone mineral density using data from the study of osteoporotic fractures, or SOFT study. And in that study, there were 6,201 women who participated in the study. And we measured bone mineral density at the heel and the spine. We found what we did was we compared daily users to non-users, and we compared intermittent users to non-users. And the reason we did that was really because we thought that perhaps this intermittent use would be higher given a tachyphylaxis response. And what we did notice was that daily users compared to non-users had similar density at the heel and the spine, but intermittent users had much higher bone density. There was similar data using an open label trial comparing conjugated estrogen or transdermal nitroglycerin, and the nitroglycerin was given once a day. And that found equal bone mineral density between the two groups at 1 year. This is the study that I alluded to earlier. What you can see here is the percent difference in bone density among nitrate users compared to non-users. So the first sort of column there is daily users compared to non-users, and on the right-hand side, versus non-users. And you can see that there is no real difference in hip or heel density among daily users compared to non-users. However, intermittent users had about a 3% increase in hip bone density and about a 5% increase in heel density compared to non-users. There's also been some data, observational data, looking at nitrates and fractures. And this was work in Denmark. And they looked at about 120,000 subjects who had fractures. Those were the cases. And then about 400,000 controls. And then they looked at self-reported nitrate use between 1995 and 2000. And they found that nitrate use was associated with a decreased risk of any fracture. The odds ratio was about 0.89. And hip fracture specifically with an odds ratio of 0.85. So what the studies have really found so far is that nitrates, organic exogenous nitrates, are associated with increases in bone density, and that they may also decrease the risk of fractures. Further, given the data on frequency, suggests that there may be a tolerance to nitrates that may exist. So this really led us to our second study, which was really to test in a more formal way the effects of nitrates on bone. And we did a randomized controlled trial to look at the effects of isosorbide mononitrate on markers of bone turnover. We also wanted to look if there was a dose response. We applied for funding in 1998. We received funding in 1999. The study was completed in 2000 and published in 2004. And this was the design of that study. It was a sort of two-phase study. Everyone in the phase 1 received calcium and vitamin D. And then for the second phase, they were randomized to isosorbide mononitrate 5 milligrams, isosorbide mononitrate 20 milligrams, or placebo. And patients were instructed to take the isosorbide or placebo once a day. Just for those of you who aren't familiar, the typical way that isosorbide mononitrate is prescribed is 20 milligrams 3 times a day. So this was far less than what's typically prescribed. After 3 months of calcium and vitamin D, we measured blood and urine for bone markers, and then we measured those markers again at 6 months. We included postmenopausal women, 50 to 80 years old, who had osteopenia or normal bone mass at the femoral neck. We included women who'd had osteoporotic fractures, who had active bone disease, who were undergoing treatments for osteoporosis, or who were taking treatments with steroids, or who had heart and who were using nitroglycerin for that reason. We measured 2 markers of bone turnover, those that captured osteoblast activity and those that captured osteoclast activity. And I just wanted to remind you that typically resorption and formation are coupled. So in menopause, for example, we have excess resorption or breakdown, but we also have increased formation. And with medications such as bisphosphonates, which are anti-resorptive agents, we decrease resorption, but we also decrease formation. Now, we have reason to believe that this may be different with nitroglycerin as isosorbide mononitrate specifically, because the animal and in vitro data demonstrate this independent and biphasic effect on osteoblasts and osteoclasts. So we thought perhaps we would see an uncoupling of bone turnover. Why did we measure biochemical markers for this study? We did it because we knew that biochemical markers are correlated with changes in bone mineral density, and you can see substantial changes in markers within about 3 months. This was the first randomized trial really looking at isosorbide mononitrate in otherwise healthy postmenopausal women, and by picking a surrogate outcome, bone turnover markers, we really were able to have a short study that minimized and I think more importantly would have minimized any adverse events with nitroglycerin in these patients. So I won't spend a lot of time on this, but I'll tell you that we screened about 450 women. 245 were eligible, and of that we randomized 144, 44 to the placebo, 44 to the 5 milligram isosorbide group, and 42 to the 20 milligram isosorbide group. You can see that we did have dropouts, particularly higher levels of dropout in women that were randomized to the 5 and to the 20 milligram group of isosorbide, and I'll talk to you about that in a minute. These were the characteristics of our patients. What you can see is they were on average about 60, weighed about 74 kilograms. Most were white, with sort of 13 years or so of menopause. There were no differences in bone turnover markers at baseline. And I apologize for that little overlap there in the column. What we found is that isosorbide mononitrate decreased bone resorption, so decreased bone turnover, and this is the percent change compared to placebo. The first bar is the 5 milligram group. The second bar is the 20 milligram group, and you can see the decrease was about 36% in women who were randomized to 5 milligrams and about 45% in women who were randomized to 20 milligrams. And in contrast, there was an increase in bone formation, about 15% in women who were randomized to 5 milligrams and about 23% in women who were randomized to the 20 milligram group. The other issue is the headache issue. So I pointed out to you on that flow sheet, we had dropouts, particularly in the 5 and 20 milligram group. And most of those dropouts were due to headache. So there was differential dropout due to headaches associated with the isosorbide mononitrate. Obviously, the limitations of our findings are the generalizability, the short duration, and the fact that we really looked at a surrogate, not BMD and not fractures. What do our findings mean? Well, to put it in context for you, the decrease in the NCX is similar to what's been found with bisphosphonates. They typically report about a 40% decrease in NCX, and that has in the literature been reported to be associated with about a 30% decrease in fracture risk. The other thing that I think is very intriguing is the increase in bone formation. Perhaps this would lead to greater fracture risk reduction, but we don't know. I think the other thing, clinically speaking, is that headache may limit the use of this drug. Headache was common in women randomized to nitroglycerin and accounted for most of the dropouts. It was higher than what's been reported in the cardiovascular literature. And the earlier study, which looked at transdermal nitroglycerin, demonstrated less headaches. So there was perhaps a theory that there may be less headaches if we gave a different formulation of nitroglycerin. We then went on to do our third study, and this is the last bit of data that I'm going to share with you today. We applied for funding to CIHR for this in March 2004, rejected. We reapplied for funding March 2005, and it was funded in October 2005. The trial was completed March 2010, and we managed to clean and analyze our data within about a month after completing the trial. This was a two-part randomized trial, and it consisted of a 3-week crossover study that compared the tolerability of nitroglycerin, the transdermal, to isosorbide mononitrate, and then we did a 2-year study of whatever the best tolerated nitrate be. The outcomes in our study were change in lumbar spine and hip bone density, and change in spine bone density was our primary outcome. We also looked at changes in bone turnover marker, and then we looked at trabecular bone changes with peripheral computed tomography. We hypothesized that 15 milligrams of nitroglycerin applied once daily would lead to uncoupling of bone turnover, increases in bone mineral density and bone geometry compared to placebo. Now, what I'll just share with you before we go further is that in our 2-week crossover study, we found that women tolerated the nitroglycerin ointment, which is what we went on to use in our 2-year study, much better than the isosorbide mononitrate pill with regard to headache. So after we identified the ointment as being the agent we would go with, we had a 1-week run-in phase. And what we did in that 1-week run-in phase is everyone got the nitroglycerin ointment and they applied it every night for a week. Those who did not get headache were then randomized to either a placebo ointment or an active. The study was 24 months in duration, and we measured, as I've told you, bone mineral density, bone turnover markers, and PCCT. We included women who were postmenopausal, at least 50 years old, and who had bone density T-scores between 0 and -2. We excluded women who had migraine headaches. Our thought was that the headaches may be exacerbated by nitroglycerin, women who were already taking nitrates, and women who were hypotensive, systolic blood pressure less than 100, or diastolic blood pressure greater than 110. Our primary endpoint was lumbar spine bone density change at 24 months. We also looked at hip bone density, femoral neck, and total hip. We looked at PCCT measurements, which really measure bone geometry at the radius and tibia, and we looked at bone-specific alkaline phosphatase, the ALP, and urinary NTX. I don't want to spend a lot of time on this slide, other than to just show you that we assessed 1,500 women to see if they were eligible, and of those we enrolled 400 in the run-in phase. About 104 women who were not interested in participating did not participate due to headache. Of the 243 women that we randomized, about 7 in the nitroglycerin group discontinued due to headache, and 2 in the placebo group discontinued due to headache. So again, we're seeing this differential with regard to headache. This just shows you very briefly some of the characteristics in our study subjects. There were 126 women who were randomized to the ointment, 117 women who received placebo ointment. They were roughly 60, weighed 70 kilograms. They took in adequate amounts of vitamin D at baseline as well as calcium and did not have osteoporosis. This shows you the change in bone-specific alkaline phosphatase at 12 months. And the next 2 slides are similar, so I'll just orient you. On the y-axis is the percentage of baseline in terms of change in bone turnover marker. The red is the nitroglycerin group, and the blue or greeny color is the placebo group. So you can see that at 12 months, the nitroglycerin group had a 21% increase in bone alk phos compared to the group randomized to placebo. That increase widened over 24 months to 35.9%. So again, nitroglycerin group had a 35.9% increase in bone alkaline phosphatase compared with placebo. This shows you the urinary NTX. So again, the red is the placebo, the greenish blue is the nitroglycerin. You can see that at 12 months there was a 30% decrease in urinary NTX to nitroglycerin compared to placebo. And this increase or difference widened so that at 24 months, the nitroglycerin group had the placebo group had a 50%, the nitroglycerin group had a 50% decrease in urinary NTX at 24 months. This shows you the lumbar spine bone mineral density. And what you can see is over 24 months, there was about a 6.7% greater increase in lumbar spine bone density compared to placebo. And this looks at femoral neck. So again, you can see compared to placebo, there was about a 7% increase in femoral neck bone density over the 2 years. Hip bone density was also increased by about a 6% increase in hip bone density in the nitroglycerin group compared to placebo. I won't spend a lot of time on this other than to say that if we looked at bone geometry, there was an increase in trabecular density, cortical thickness, cortical density, cortical area, and periosteal circumference. at the radius, so they all improved. And if we looked at bone strength by looking at polar section modulus and polar moment of inertia, they were increased at the radius as well. Similarly, the tibia, we saw increases in trabecular density, increases in cortical thickness, cortical area or periosteal circumference. And again, if we looked at indices of tibial bone strength, there was an increase in polar section modulus and polar moment of inertia in the tibia. In terms of side effects, really the only side effects we saw in our study were headaches. And the headaches were preferentially more frequent in women that were randomized to nitroglycerin compared to placebo. And what you can see is that over time, the frequency of headaches sort of diminished, both in the nitroglycerin and the placebo group. Most of the women who, actually all of the women who dropped out in the study dropped out by 12 months. And that happened, again, preferentially in the nitroglycerin group. In terms of serious adverse events, these were adverse events requiring hospitalization. There were 5 in each of the nitroglycerin and placebo group. There was 1 death in the nitroglycerin group, and this was due to stroke. And our Data Safety Monitoring Board did not think there were 2 fractures in the nitroglycerin group and 2 fractures in the placebo group. So, the conclusion. Nitroglycerin uncouples bone turnover. We saw an increase in bone formation and a decrease in bone resorption. Our data demonstrates that it improves bone density at the lumbar spine, the femoral neck, and the total hip. It also improves bone geometry at both the at both the radius and the tibia, and it improves indices of bone strength. Nitrates are inexpensive and they are widely available. One pragmatic limitation, I think, is the headache, which appears to be most common when the drug is started, and it does seem to wane with duration of use. I think the efficacy of nitroglycerin to reduce fracture risk needs to be tested in a clinical trial. And I'm going to end there, and I guess we can open this up for questions.
Sophie, so you'll just have to turn off your Lock Talk if you haven't done so already.
Okay, I just did that.
Thanks a lot, Sophie. So Linda's question, I think you addressed. Linda Lippert had typed one into the chat area, and she just asked, other than headaches, what other side effects were seen, and I think you said none.
Yeah. I mean, really, headaches was the big side effect and was associated with most of the dropouts. The hospitalization we saw were for things like flu and pneumonia, and then there were 2 fractures in each of those 2 groups, so nothing else in terms of looking at that group for adverse events.
Great. So if anyone else has any questions that you'd like to ask verbally, you can use the hand raise button that we tried out at the beginning of the webinar, and just click that button and a number will appear beside your name. Or if you're feeling shy and you don't want to ask a question verbally, you can do so in the chat area. So are there any other questions? Now's your last chance to ask them in the webinar. Linda's asking if headaches were reduced with Tylenol, etc.
Yeah, headaches were reduced with Tylenol, modestly in some people. Most people who got headaches describe them as sort of almost like a migraine type headache, which is not inconsistent with the mechanism because it probably does come from vasodilation, but sometimes the Tylenol helps. So, yes.
Ashley, yes, the PowerPoint. Go ahead, Sophie.
Yeah, I was going to say yes, I guess the PowerPoint will be available.
Yes, I will post it up on our website.
And then the other question was from Melissa Lang. Are headaches due to the vasoconstrictive effects of the NO? Actually, they're due to the vasodilation. So the nitric oxide actually goes directly to the endothelium and causes vasodilation. That's the mechanism by which it reduces angina. And that's thought, some people are thought to be more sensitive to that in terms of getting the headache.
That's great, Sophie. So on the slide where you were talking about the headaches, you said that there was one death. And what was the death was caused by stroke? Sophie, can you hear me?
Sorry, yes. The death was due to stroke.
Okay, and there's a question there from Louise. How much vitamin D was supplemented, and was there any control on vitamin A levels?
So we actually took detailed dietary histories from all the patients with regards to calcium and vitamin D. All of the patients took in 1,000 international units of vitamin D. So if they weren't taking it already, we provided that for them. And we really didn't encourage people to take excess vitamin A, but other than that, we didn't measure vitamin A or do any formal controls with regards to vitamin A.
Great. Are there any more questions? Anybody? Sophie, would you mind sharing your email address with us in the chat area, so if anybody thinks of any questions after they have a chance to digest the information, they can send you an email? Or
yeah,
if
absolutely.
You want,
I'll put it in now.
That's perfect. So if anybody is interested in contacting Sophie directly, there's a few discussions going on there in the chat area, Sophie. I don't know if you want to address those.
So I guess the question was, a retinol cream could thus wipe out the effects of the D. I'm not familiar enough with those interactions to comment. One of the nice things about it being a randomized trial is that, people who were using retinol potentially would be equally distributed between the two groups. So even if there was a D effect, I would assume that it would be a retinol effect. I would assume that it would be equally distributed.
Thanks, Sophie and Louise, for your questions. So we're going to end the webinar there. I want to thank Sophie for sharing her research with us, and also thank CIHR for making our webinar series possible. They've generously provided funding so that we can offer these 6 webinars to our participants free of charge. And thank you everyone who is in the room today. Many of you have been in webinars before, and some of you are new. We do have another webinar coming up on February 22nd, I believe. Yes, February 22nd at 1 p.m. And that one will focus on community-based physical activity programs for stroke. So you may have already received some information about that, but you can certainly register for that as well. And finally, if you are interested in getting a certificate for attending this webinar, you can do so from the main room where you clicked on the link to get to the launch page of the classroom. You'll see there's a little short survey there that you can respond to, and once you respond to the survey, the certificate should be released to you. So thanks again, everybody, for joining us, and hopefully we'll see many of you back on February 22nd, and thanks again, Sophie, for sharing your information with us. Bye-bye.
Bye-bye. Thank you.